Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for a successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to Talking Prostate Cancer, a CME program that's focused today on homologous recombination repair gene mutation testing in men with advanced and metastatic prostate cancer. Dr. Dorff and I are going to take a deep dive into the rationale, guidelines, and implementation of genetic testing in prostate cancer and some of the reasons and dramatic changes in practice algorithms that all of you are experiencing in clinical practice. The CME program is brought to you by Rush University Medical Center and Practice Point Communications, and is generously supported by an educational independent grant from Janssen Biotechnology. I'm Dr. Andrew Armstrong. I'm a professor of medicine, surgery, pharmacology, and cancer biology at Duke here in Durham, North Carolina. These are my disclosures.
Tanya Dorff, professor of medicine at the City of Hope in Southern California, and my disclosures are listed here.
Great to have you, Tanya. Thanks for popping your head in. So here are the learning objectives for our conversation today. This is a unique program that Dr. Dorff and I are experiencing in real time with you. So we are going to hopefully by the end have discussed the prevalence of these homologous repair gene alterations in men with advanced prostate cancer and the rationale for doing the testing. We're going to bring the latest guidelines and evidence and strategies for that testing to your practice. We're going to identify patient subsets that you see in the clinic that will benefit from such testing, and then we'll learn to employ a very individualized, personalized approach to utilizing the testing to improve the outcomes of your patients. All right, so segment one is going to be on the rationale for testing. So let's just take a step back, and for those of you new to prostate cancer, prostate cancer is still the number one most common malignancy in men. It's the most survived malignancy in the entire United States, but it's really a tale of two cancers where, unfortunately, it's still the number two killer of men due to cancer. And so while 6 of 7 men with prostate cancer beat their cancer and survive, still about one in 7 men will face lethal disease and the consequences of that. The risk factors for prostate cancer are based on age, race, several genetic factors, which we'll be talking about, family history, but also lifestyle factors, and some of these are not, but not limited to obesity, smoking, lack of exercise, certain dietary patterns, and many military exposures. Prostate cancer is really the number one cancer in the military, and Agent Orange and some emerging exposures are contributing to that. There's a high hereditary component to prostate cancer. Up to half of all prostate cancer can be explained by differences in our makeup and gene alterations. Twin studies have also suggested this, and men with family histories of first-degree relatives with prostate cancer have a 2.5-fold higher risk of being diagnosed with prostate cancer. About 8 to 12% of all patients that we see in clinic will have germline alterations in these key DNA repair enzymes that we now consider very actionable for therapies that patients have available to them in the clinic. I'll turn the next slide over to Tanya.
Dr. Armstrong mentioned there's a strong genetic component, and there are both germline alterations as well as somatic alterations. And these seem to be both relevant in terms of response to targeted therapeutics, but they do have different implications for patients. So we have to remember that when we're talking germline, to think about the family and cascade testing. And when we detect something somatic, we want to make sure and track down whether it's actually a germline variant so that we can appropriately counsel our patients. So in addition to DNA damage response genes, we can find some other mutations, some of which are not currently actionable, but may become so in the future, like PI3 kinase, PTEN loss sort of things. Also, there can be cell cycle gene alterations. But some of the most common, as the cancer develops resistance to our androgen receptor targeted agents, do involve the androgen receptor itself. So currently, not everything's actionable, but in the future, we should have a lot more therapeutics that are based on some of these somatic alterations that develop during progression of prostate cancer. And we'll talk a little bit about serial testing in that context later.
Great, thank you. About half of the alterations in the DNA damage response pathways are germline, and that means half are not germline. That means they're acquired in the tumor, and they would not be detectable if you did a saliva or a simple blood test, but would be only detectable through tumor testing. DNA damage response pathways are really critical. Cancer is a disease of mutations, and prostate cancer is also caused by an accumulation of mutations, and particularly DNA damage response mutations seem to play a major role both in the hereditary component of cancer, but also in the vulnerability of these cancers to precision medicine therapies, particularly homologous repair deficiencies. The BRCA2 gene and other homologous repair genes are targetable and are considered actionable alterations. So learning, how to detect these mutations, both tumor and germline, is really critical.
So there are differences in the different genes that we lump together as genes affecting homologous recombination repair. Some are sensors like ATM, some are effectors like RAD51. And altogether, this is a cellular process that's obviously very critical for cell survival. DNA integrity impacts whether a cell can cycle and divide. So it is a very redundant pathway, but I think it's important to highlight that there are some different roles, and that makes sense when we start to talk about potentially differential responses to treatments like PARP inhibitors among these different specific HRR genes. And sometimes we can find that there will be multiple genes that are altered.
It is also important to realize that these DNA repair alterations can create a cancer that's very heterogeneous, genetically complicated, and these are gatekeeper alterations that, when lost, particularly the BRCA2 alteration, this can open up the stage for many other alterations to coexist in the cancer, and for that cancer to become both more aggressive but also highly resistant to our conventional therapies. And so this study shows Kaplan-Meier survival and progression-free survival plots in patients that have homologous repair deficiencies, that's in green, versus those that don't. And the control group here is those patients that have nothing detectable in their plasma, and those patients do the best. And so this illustrates the fact that patients who are treated with AR inhibitors may have an intrinsic resistance or a more rapid acquisition of resistance when they have these homologous repair deficiencies.
So we know that people who carry a BRCA2 or 1 gene alteration are at higher risk of developing cancers. In addition to prostate, this includes breast and ovarian cancer. And so it's important that, again, when patients of ours who are found to have a germline mutation are given counseling, that they think about counseling their family members with cascade testing so that appropriate, sometimes intensified or earlier or specialized screening procedures can be initiated. But as Andy just showed us, there's also an implication for the patient themselves. A patient who harbors a BRCA alteration and develops cancer will tend to have a more aggressive prostate cancer course. They may also be diagnosed earlier. But most importantly, as we'll be talking about throughout the program, this has implications for treatment.
So if we just focus on BRCA2, which is the most common alteration, both germline and somatic, and you focus on patients with mCRPC, again, you can see that BRCA2 carriers have a worse prognosis from the time of mCRPC to death, almost a doubling of this, or halving of the survival of patients that are non-carriers. So really can impact prognosis, but I think even more important, now we have therapies that can rescue this poor prognosis and almost bring the patient's survival up to the state where they almost didn't have the BRCA2 alteration, which we'll cover in subsequent slides. if we step back and look at historically how we've treated patients with MCRPC in the first-line setting, docetaxel was the first life-prolonging medication to demonstrate benefits in randomized phase 3 testing. That was 2004, 20 years ago. Since then, we've now established that first-line AR inhibitors could extend survival, and the median survival was much better in the Cougar 302 and Prevail trials, where abiraterone and enzalutamide really changed our practice and management to move these potent AR pathway inhibitors into the first-line setting, and docetaxel thus became more of a second-line setting. But at the same time, these same agents started to move into the non-metastatic and hormone-sensitive settings, where survival is even further prolonged. However, in real-world data sets, median survival is still much worse than what we see in phase 3 testing. Many barriers to care and access to clinical trials, many other, patients dealing with other comorbidities, access to care, create barriers so that the real world data doesn't look nearly as rosy as the phase 3 tests.
Unfortunately, that many patients don't get multiple lines of therapy or get fewer lines of therapy as well, which is one of the reasons that there's such an interest in combinations and using our most effective therapies as early as possible. So PARP inhibitors, just as a brief review, are functioning along the DNA repair pathway. So in most cells, because it's such a redundant process, you can suppress PARP function and still repair enough DNA. But when there's an underlying impairment in homologous recombination repair, and then you impact PARP function, it's a second hit and leads to what we call synthetic lethality, such that then we can see more cell death, particularly in the cancer cells, because they're dividing more frequently. So PARP inhibitors have been shown to be efficacious, not only in prostate cancer, but a couple of other tumors using this synthetic lethality. However, there is some underlying rationale to combine them with androgen receptor targeted agents, because there is some crosstalk between androgen receptor, DNA repair, and PARP. And so these combinations will be the focus of some of the upcoming presentation.
Thanks, Dr. Dorff. And because of that synthetic lethal relationship between these DNA repair alterations and PARP inhibitors, the initial phase 2 single-arm trials, monotherapy trials, focused largely on patients that had either germline or somatic alterations in the BRCA and other gene alteration pathways, so ATM and some of the non-BRCA genes that you've heard about. This is a busy slide, but basically all of these trials, whether it's niraparib, talazoparib, rucaparib, or olaparib, are PARP 1-2 inhibitors and often extend beyond PARP 1-2 to be drugs that induce DNA repair deficiency and lead to an accumulation of double-strand breaks and cell death, particularly in tumors that have these DNA repair alterations. The objective responses tend to be high, somewhere around 30 to 40%, particularly higher in those that have BRCA mutations. And the PROfound trial is really the only phase 3 study that's demonstrated an overall survival benefit with a PARP inhibitor as monotherapy, particularly in patients with BRCA 1-2 and ATM alterations, but largely driven by the BRCA 1-2 alterations. And so this led to the FDA approval of olaparib as really the first life-prolonging PARP inhibitor in a post-NHA and docetaxel setting. But of course, some patients are not eligible for docetaxel, and so they may receive a PARP inhibitor really as perhaps a second-line therapy. But all of these suggest very consistent activity, not in every patient. It's not 100% objective or PSA responses, but in a significant proportion of patients benefiting from this approach as monotherapy.
Now we'll look at the approvals for monotherapy of PARP inhibitors. So olaparib has been FDA approved for patients with a set of homologous recombination repair mutations. So not just BRCA1 and 2 and ATM, but you can refer to the PROfound study for the full list or the FDA label. In Europe, it's approved for patients with MCRPC who have BRCA mutation. and have progressed. In both cases, FDA and EMA, it's progression after an AR pathway inhibitor. And then rucaparib's label is for BRCA mutated MCRPC post-AR pathway inhibitor.
So we're going to talk a little bit about some of the phase 3 trials that have established efficacy for combinations now. And we're going to highlight PROPEL, TALAPRO, and MAGNITUDE, which are trials already presented, published, and which have new FDA labels just in the past year. The CASPAR trial testing rucaparib has really been ended because of decisions to discontinue the development of rucaparib. But there's a number of other phase 1 and phase 2 trials testing combinations of PARP inhibitors with any, you name it, targeted therapy, whether it's a PSMA targeted therapy, an epigenetic modifier, a PI3 kinase inhibitor, really trying to get at the non-redundant pathways that persist inside the cancer cells to allow survival and preventing cells from being killed, and which allow these persistent cells to survive and develop resistance. So stay tuned for some of these newer combinations in the future.
It's a shame that some of the PARP immunotherapy combinations, you saw one phase 3 trial was negative, but some of those combinations with radioligand therapy or with post-translational modifications, HDAC inhibitors, EZH2, those look really interesting.
Absolutely.
But coming back to the AR pathway inhibitor combinations, which have multiple successful phase 3 trials, we have PROPEL, which was abiraterone with olaparib or abiraterone with placebo in first-line MCRPC. So these are patients who have not progressed on an AR pathway inhibitor because these trials were really designed before the upfront intensification with doublet therapy was common. And you can see a significant benefit in the primary endpoint of radiographic progression-free survival with a hazard ratio of 0.66. There was also a survival benefit seen in PROPEL, and we'll look at each of these in a little more detail. MAGNITUDE had a slightly different design in that the HRR status was known up front and patients were assigned to one of two cohorts, either HRR mutated or not, whereas PROPEL and TALAPRO-2 took all comers and then looked at the HRR status later during the analysis. So because of that, we have some different results with MAGNITUDE that I think we'll address later. But again, it was positive for the RPFS in the HRR altered cohort with a hazard ratio of 0.73. And then TALAPRO-2 was enzalutamide and talazoparib or enzalutamide and placebo in first-line MCRPC. RPFS was the primary endpoint and a statistically significant benefit with a hazard ratio of 0.63.
Great. And the primary endpoint, again, for PROPEL was an all-comer RPFS endpoint. And that was intended intentionally to get at this benefit of inducing BRCA with a AR inhibitor. AR regulates DNA repair itself. And the thought was that maybe in all comers, you wouldn't necessarily have to have a PARP-sensitive mutation to benefit from the combination as long as the abiraterone itself was inducing DNA repair deficiencies, which we all understand from the radiosensitization of hormonal therapy, for example, the same basis. So the primary endpoint of RPFS was met. You can see on the left, the investigator assessment, there was about an 8-month delay or hazard ratio of 0.66, and on the right, that was blinded independent review, a 11-month benefit in RPFS, hazard ratio of 0.61. And just to point out, the abiraterone did about as expected. The median progression-free survival was 16 to 17 months. And so this is the combination showing superiority to our best standard of care at the time in this first-line MCRPC setting. So this was a successful study for its primary endpoint in the overall population.
Overall survival in PROPEL was also positive, but here we see a much stronger benefit in the population that had an HRR mutation, whereas we don't see a statistically significant benefit when you consider the intention to treat overall population. So this was not the primary endpoint, but I believe these data were considered when decision-making was being made in terms of which populations to apply this combination to in the label.
I think that's right. And I think when you see this survival curve, you realize the FDA's position was to approve olaparib in those patients most likely to benefit, which is those patients that have a germline or somatic BRCA1 or 2 alteration. And that's because of a hazard ratio for overall survival, 0.29, which is a huge difference. I think that is the greatest hazard ratio in any drug trial for overall survival. But of course, it is a subgroup analysis. It is a smaller subgroup, but it's a large benefit. That doesn't mean there aren't benefits in other subgroups. It's just that BRCA1, 2 patients are largely driving a major benefit. And so that has certainly changed labels and changed practice, both here and abroad.
It's a really striking hazard ratio for survival and just speaks to the importance of these PARP inhibitors for patients with BRCA alterations in particular. The earlier, the better. Magnitude, as I mentioned earlier, had a different design. So the non-HRR cohort was separate, whereas in the other 2 trials that we're discussing, it was mixed in. And that cohort was closed for futility. So we're only seeing the results in the HRR altered population. But here, the combination of niraparib with abiraterone did result in a statistically significantly better rPFS than placebo with abiraterone, with the hazard ratio of 0.73. You can see that the benefit was even stronger in the BRCA1 and 2 mutated cohort with a hazard ratio of 0.53.
And overall survival is an important secondary endpoint in magnitude. And I think, if you looked at that slide that I showed you from PROPEL, the survival of patients with BRCA2 is worse, when treated with abiraterone as compared to non-BRCA2 patients. While the patients who receive the combination, they really are rescued and have a much better survival equivalent to that of the patients that have no BRCA2. In magnitude, there was a trend towards improved survival. This did not meet the pre-specified criteria for significance, but when the authors did a pre-specified multivariable analysis accounting for imbalances at baseline, there was a suggestion of significance. I think overall there's been very consistent findings for the AR-PARP combinations. However, not all of these PARP inhibitors are the same. You'll see different data sets for efficacy and also for safety, which we'll cover.
That's a good point, Andy. These are different, and there can be some differences in dosing when we combine. And so it's really important to stick with how the trials were done, check the dosing, and use the appropriate combinations. Don't mix and match, in other words. Some other secondary endpoints for magnitude included time to symptomatic progression and time to chemotherapy. These are very meaningful for patients in the clinic, and you can see that they were significantly prolonged in the combination of niraparib with abiraterone compared to abiraterone with placebo.
So not all patients benefit from abiraterone, and having a choice of a different AR inhibitor is really critical. We're all used to using enzalutamide as a first-line therapy in the MCRPC setting based on the PREVAIL study. Enza has other drug interactions. It can be a cytochrome P450 inducer, and so it's very important when studying Enza combinations to do careful drug-drug interaction studies. That was done in TALAPRO-1, and TALAPRO-2 took advantage of some of those drug interaction studies to combine talazoparib, another PARP inhibitor, with Enza at a dose that was safe, 0.5 milligrams. And so this combination was superior, again, in the primary overall intent to treat population, irrespective of BRCA alterations or HR alterations. Enzalutamide in TALAPRO did about as we'd expect in terms of progression-free survival, about 22 months, but talazoparib plus Enza outperformed Enza as an active therapy in the all-comers, meeting the pre-specified protocol progression-free survival criteria. So a big difference overall in these 2 curves for the all-comer population.
PFS in the HR altered population, we can see again a very strong improvement with the median rPFS not reached with talazoparib plus enzalutamide compared to 13.8 months for enzalutamide. Again, this is shorter than what we saw in the all-comers because of the impact of HR alterations on overall disease course.
A common question that I get is, are all these HR genes created equal? And, at the recent consensus conference that we had, this was very clear that there was not clear consensus on these genes. There is consensus that the BRCA1 and 2 patients benefit the most. And I think you can see on this forest plot where to the left is a clear benefit for the combination, that BRCA2 has a huge benefit both in PROPEL and in TALAPRO in driving the survival and progression-free survival benefits. But what about these other genes? I think there's where some nuance comes in. And there was a recent FDA meta-analysis that looked at this. This is from TALAPRO2. And I would say from TALAPRO2, you can see that PALB2 and CDK12 are more to the left than ATM and CHEK2, which tends to be right lined up with 1, suggesting not as much benefit in the ATM and CHEK2 carriers, but some suggestion of a more moderate but significant benefit in the PALB2 and CDK12 carrier. So, I think there is some nuance to this, and the individual genes do matter, and these clusters of genes do matter. So as you're doing precision testing, both somatic and germline, we'd encourage you to look at this data to decide on the overall net risks and benefits to your patient.
The PARP inhibitor combinations have now been FDA approved, and the summary is presented here. Olaparib with abiraterone in those patients with BRCA mutated mCRPC, niraparib abiraterone in the fixed dose tablet, which is available for BRCA mutated mCRPC, and talazoparib in combination with enzalutamide for mCRPC patients who have HRR alterations.
It's important to realize that if you live in a different part of the world, you may get a different approval. In Europe, olaparib in combination with Abi has a broad indication. Basically, there's no genes mentioned in the label, and that's how PROPEL was designed, instead of a retrospective subset analysis. And so the olaparib label in Europe is for patients with mCRPC, first-line setting for whom chemotherapy is not indicated. Niraparib Abi is restricted to the BRCA1/2 mutations, where the most benefit was noted in the magnitude study. And just like PROPEL, the talazoparib approval was based on how the study was designed and the patient population under study, and that positive endpoint led to a broad approval, identical to the olaparib label. All right, so like I mentioned, there is some nuance to this, and the FDA has a collective of all the data, PROPEL, Magnitude, TALAPRO, and some of the other smaller studies, where they've pooled all of these gene-by-gene analyses together and looked at the PFS and overall survival data by these genes. And I think on the right, you can see the hazard ratios are very close to 1 for both rPFS and OS for ATM, suggesting that we're not yet good enough to predict who of the ATM patients are benefiting. And I think there's some work still to be done on developing a better ATM biomarker like immunohistochemistry for ATM loss and excluding CHIP, which is clonal hematopoiesis. That means an ATM alteration that's not even in the tumor, it's in the white blood cells. For BRCA1 and 2, I think the data is very clear that there's a huge benefit both in PFS and OS. And I think you can see that in the meta-analysis here, which lumps all the PARP inhibitors together, by the way, which again, I don't think we should do since they're not all the same in terms of efficacy or safety. And there's the highlighted parts of the table.
Agree, Andy, that not all the PARP inhibitors are the same, and yet we've just been struggling to put together enough of a data set with these more rare mutations to try to get a sense of how these drugs are working.
Yep.
So here we see that CDK12 did look like a patient population that had a strong benefit from PARP inhibitors, and I believe this is the pooling of the monotherapy trials. Whereas, and also PALB2 came out strongly benefiting, whereas the CHEK2 population did not seem to benefit as much.
Just point out, Tanya, these are the combos because it's the ARPI-PARPI combo versus the...
Okay, sorry.
If you look under the arm there.
Oh, right.
Yeah, and here are the Kaplan-Meier plots. Again, this is like a mashup of Magnitude, PROPEL, and TALAPRO. And just looking at the survival curves, I think, tells you the whole story. So in the upper left, you got ATM. The curves are directly overlapping. If you look at the bottom, BRCA2 in the bottom left, those curves are hugely divergent. So you have basically a negative control with ATM, a positive control with BRCA2. And then I think in the middle, you see BRCA1 on the left. There's some modest benefit, CDK12, modest benefit, PALB2, modest benefit, and CHEK2 on the middle right, basically no clear benefit. So all these nuances, I think, are impactful when you're communicating to patients. Is there a benefit to the combination? I think it's very clear for BRCA1, BRCA2, and then CDK12 and PALB2. There's clearly some benefits, which, may outweigh those risks that we're going to talk about in terms of toxicities, but that's very much an individualized decision. The conclusion of this part one is that I think you hopefully understand that somatic and germline mutations are very important. If you just did germline testing, you'd miss half of the mutations, particularly in the BRCA pathway. They're both associated with poor outcomes, but also sensitivity to PARP inhibitors. PARP inhibitors have shown efficacy as monotherapy and now in combination therapy. And I think you've seen that even though we may have learned that as monotherapy, some of these genes may not have created a great response like CDK12 or ATM or PALB2, but with combinations, you do see some synergy between the AR and PARP pathways where there's the greatest benefits in the BRCA patients and less but real benefits in CDK12 and PALB2 patients, much less so in any other subgroups. So therefore, there's a strong rationale both for testing and to use that testing to inform therapy.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.